Good afternoon, ladies and gentlemen. My name is Demi, and I will be your host for today. Thank you for joining us in today's webinar entitled Parkway Lives. This will be a series of webinars that will discuss different topics, all related to health. Today's topic is all about raising awareness on stroke. We have two specialists with us today who will be discussing stroke prevention and management, as well as the heart and brain connection. The leading providers of private healthcare services in Asia. Parkway Hospital Singapore operates 4 hospitals: Gleneagles Hospital, Mount Elizabeth Hospital, Mount Elizabeth Novena Hospital, and Parkway East Hospital. With multidisciplinary specialists, they offer the most advanced medical treatments, leveraging on its pursuit for quality excellence, comprehensive clinical programs, and facilities. Parkway Hospital Singapore seeks to be the global leader in value-based integrated healthcare. But before we get into the meat of our webinar today, we will have a quick icebreaker activity. So I would like everyone to please participate in this icebreaker activity. This is called myth or fact. So we will be displaying statements, and I would like you to guess or decide whether it's a myth or a fact. So yes, click onto the chat box and type in your answer. So let's get the ball rolling. Let's look at our first statement. A second stroke will have worse effects than the first. Let's see what everybody thinks. Do you guys think this is a myth or a fact? Oh, wow. Okay, a lot of us think this is a fact. We got one person thinking this is a myth. Oh, 2 people now. Okay. 3 people. All right. Okay, I can see a lot of people thinking this is a fact and maybe a minority thinking it's a myth. This is very interesting. All right. So we won't know the answer to this just yet, but later during our open forum, we have our specialists who will confirm our answers, whether we got it right or wrong. So I suggest you list down your answers so you can check later on if you got it right. Let's go on to the second statement. Only old people experience strokes. Okay, we've got some fast answers here. Mostly myths, mostly missed. Okay. Nobody thinks it's a fact? All right, I think we've got a majority here. Everyone's thinking this is a myth. Okay, quite interesting. Let's move on to the third one. Women are not likely to have strokes. As a woman, I wish this was right. I really do wish that us women don't experience any of these illnesses, especially a stroke. But a lot of you are saying this is a myth. Okay. Oh, we do have one person who thinks this is a fact. Interesting. All right. All right. So we've got a majority thinking it's a myth. All right. Let's move on to the fourth statement. Smoking raises your odds of getting a stroke. Clarence, very fast there. Oh, okay. We've got a lot of answers coming in, lots of facts. Okay, okay. Is anyone going to go against the grain and say that this is a myth? Oh, we got one person going against the grain. All right. Oh, this is interesting. I kind of want to ask Sophia why you think this is a myth. All right, but it's okay. Let's move on to the final statement. So all strokes have noticeable symptoms. Myth, okay. Fast answers over here. We've got a fact, okay. All right, interesting, interesting. Lots of people are answering myths, but there are a few people who are saying this is a fact. So I think the first statement and the fifth statement, there's more diversity in answers. All right, so make sure that you remember the answers to the statements, your answers to the statements, and we will confirm them later on during our open forum. All right, let's dive into our first presentation to talk about stroke prevention and management is Dr. Wee Chee Keong. He is a consultant and neurologist at Mount Elizabeth Hospital in Singapore. His main clinical interest is in acute stroke treatment. In 2018, he also co-chaired the 17th Singapore International Stroke Conference. So without further introduction, I give you Dr. Wee.
Hi, good afternoon. My name is Chee Keong. I am a neurologist. My practice is based in Parkway hospitals, specifically Mount Elizabeth Hospital in Singapore. The talk today is meant for the layperson to help increase awareness of this common condition called stroke. Thank you for spending time with us this afternoon, and thank you, Parkway, for organizing the talk. Now, before we start, I'd like to give us a brief outline of what we will discuss today. Well, firstly, we will talk about the size of the stroke problem and explaining the details of what happens during a stroke and the effects on the sufferer of a stroke. Afterwards, we will talk about the causes of a stroke, what we can do for treatment, and how we can prevent it. Now, we know that stroke is a major health problem worldwide. In most countries, it is one of the major or the leading causes of mortality and death. A paper published in the New England Journal of Medicine in 2018 estimates that 1 in every 4 persons would have a stroke in their lifetime. So this affects everybody. For myself, from my country, Singapore, which is in the little dot in red over there, the lifetime risk is about 17 to 22% per year. So we expect in a room of 4 or 5 people, 1 of us will get a stroke. So it is a major problem. But what is this disease called a stroke? The definition from the WHO is that stroke is a problem of the blood vessels supplying the brain. And there are 2 basic types, namely the ischemic stroke and the hemorrhagic stroke. Now, the most common type of stroke is the ischemic stroke. That's about 80% of strokes. This happens when the blood vessel supplying the brain is obstructed, most of the time by a blood clot. Hemorrhagic strokes make up the remaining 10 to 20%, and most of it is caused by bleeding into the brain from the blood vessels that ruptured. The other type, the subarachnoid hemorrhage, occurs when bleeding occurs just outside the brain in the subarachnoid space. This is rarer, but it's more dangerous and has a higher risk of mortality. For the remainder of this stroke, we will talk about mostly ischemic strokes. But first, just to show you how we doctors diagnose stroke. So an example of the imaging that we use to help us tell the difference between an ischemic and hemorrhagic stroke is a CT scan. So what we have here on the picture on our left is a CT scan of a person who has got an ischemic stroke in the brain. Within minutes of the blood vessel being obstructed, brain cells start to die, and this shows up as what we call hypodense area or darker area in the lower right corner. A hemorrhagic stroke is the opposite. What you see is a bright area on the right side of the brain where blood has bled into brain tissues, causing it to expand and swell. This is what we also call intraparenchyma hematoma. Now, for the rest of the talk today, we will talk more about ischemic strokes, which is the majority of the problem. Now, what happens during an ischemic stroke? Well, the graph below shows what happens at the cellular level. When neurons, which are highly sensitive cells in the brain, have the blood supply interrupted, they start to lose function. Irreversible damage occurs in the subsequent minutes as these brain cells die. And unless doctors manage to restore the blood flow within a few minutes or hours, the damage is irreversible and the patient sustains permanent damage to the brain. How does this manifest clinically? Well, to understand that, we need to understand how the nervous system is organized. In the human body, the right brain controls the left half of the body, and the left brain controls the right half of the body. And because of how tightly the neurons or the brain cells are packed in the brain, usually an area of damage on one side of the brain, left in this instance, will cause symptoms on the entire right side. So typically in a stroke, you would expect to have simultaneous weakness in the face, arms, and legs. One of the greatest concerns that my patients have after a stroke is whether they will become disabled or handicapped. At this point, I'd like to introduce to us this medical term, the Modified Rankin Scale, or the MRS. This is the scale that doctors use to measure a person's outcome after a stroke. Now 0 is the best score, meaning they have 0, no symptoms at all, or 6, which is the worst, meaning death. Usually for stroke patients, they do recover after a stroke, but that recovery maximizes or plateaus after the first 3 to 6 months. I'm sharing with us now a study that looked at the functional outcomes of a cohort of German stroke patients 100 days after they had an ischemic stroke. Although these are German patients, the numbers we see here are similar to what we see for stroke patients worldwide. So at the end of the first 100 days, which is about 3 months, 20% of patients have complete functional recovery. They have no symptoms at all, and they score 0 on this MRI scale. 26% of patients have a little bit of symptoms. Perhaps it was a little bit of weakness or numbness, but they have no restrictions in their usual activities. That means if they were playing sports, they were playing golf or badminton every day, they went back to doing that. Another 15% of patients are left with more severe symptoms. They also have some weakness or numbness on one side of the body, but unlike those with MRIs of 1, they are unable to go back to their usual activities, meaning perhaps they couldn't play golf anymore. But these people remain independent and they are able to care for themselves. So you can see the modified Rankin Scale score of 0 to 2 represent good outcomes. So what happens to the remainder? Those with a modified Rankin Scale of 3 have moderate disability. They need help with the activities of daily living, such as dressing or bathing, but crucially, they are able to walk by themselves, but perhaps with a walking stick or walking frame. At MRIs 4, they have even worse disability. Similar to 3, they need help with their daily activities, but now they are unable to walk. At MRI scale of 5, which is even worse, the stroke patient is now so disabled that they require constant nursing care and attention and cannot be left alone by themselves. Finally, 6, which I've said earlier on, is death. So this is for the first 3 months after a stroke. What happens in the longer term? Well, the Perth Community Stroke Study gives us an idea of what to expect. What they did in this study, they followed up 6,000 patients in the first 10 years after they had a stroke. At the end of the first year, what they have found is that 11.5% of these patients have demise. And that is in patients who have received medical care for stroke. The corollary is that in patients who have not received any care, the estimation is 62% of them will be either dead or disabled at the end of 6 months. We follow up these patients for 5 years, and this is what we see. 42% of them have survived. 18% of them had another stroke. 36% of them are disabled, and 14% are so disabled they needed to be in a nursing home. Overall, stroke tends to reoccur. At the end of the first month, the reoccurrence rate is about 3%. At the end of the first year, about 11%. And for subsequent years after that, it is 4% for every year. So it is very important that we prevent a stroke after it's occurred. But let's look at the risk factors to see why a person gets a stroke in the first place. The interstroke study that was published in Lancet in 2010 suggests that there are 10 modifiable risk factors that are associated or potentially causes 90% of all the strokes worldwide. The bars on the left show the magnitude of the effect, meaning how much risk these risk factors give to an individual patient. And the percentages on the right reflect the number of strokes they are thought to cause in the entire population. I've highlighted the bottom 3 because those are the ones that most greatly increases the individual person's risk of having a stroke. So potentially, if we were to treat all of these risk factors, we can significantly reduce our own personal risk of a stroke and that of the whole population at large. However, not all causes are treatable, and one untreatable cause is age. Because no matter what happens, we know that the risk of stroke doubles for every 10 years of age after the age of 55. Now, how do we treat strokes? I mean, this topic is going to be too big that I cannot explain this to us within the scope, within the timing of this talk, but I thought it's good to share with us a few things to broaden our general knowledge. Now, typically when a person has a stroke, doctors in the hospital would conduct investigations to find out what the underlying cause is. The purpose is so that we can target treatment to prevent the recurrence of a stroke. And I've said to you guys earlier that it is about 11% in the first year. This is what we call secondary prevention. Sometimes surgery might also even be needed in the acute phase, just after a stroke, or even later on to prevent stroke recurrence. And finally, for most, if not all stroke patients, rehabilitation is an integral part of the treatment, but I do not have time to explain more about that. Now, for medications, you will hear that most people after a stroke will receive blood thinners. This would usually be divided into two classes of medications: antiplatelets, which are commonly aspirin and Plavix, and anticoagulants. This would typically be drugs like warfarin, rivaroxaban, apixaban, and dabigatran. Now, these drugs are less commonly used because they have an increased risk of bleeding, but are extremely useful for patients with atrial fibrillation, a particular cardiac cause of stroke that increases a person's risk of stroke recurrence by a big amount, such that they warrant the increased bleeding risk from these anticoagulation medications. I'll sidetrack now to just talk a bit about atrial fibrillation so that we have an idea of what this is all about. Atrial fibrillation is a condition where the top two chambers of the heart, which we call the atria, do not beat properly, but they fibrillate. So just vibrate a little bit. And because of this vibration, the blood doesn't flow very well within the atria, and clots tend to form. Were these clots to drop out and flow into the bloodstream with the rest of the blood, there is a chance that these clots will lodge within the brain and obstruct the blood vessel. A stroke then results. To detect atrial fibrillation, we commonly have to put the patient on ECG monitoring, and this can be implantable or external monitoring devices. Recent studies have shown us that implantable devices are much better than external devices, but for these details, I will leave to my cardiologist colleague, Dr. Edgar Tay, who will speak to us more about that later on. I'll go on now to talk to us about a special form of a stroke, which very unusually will require surgical treatment, and that is the malignant MCA infarction. What is that? Well, the largest artery within the brain is the middle meningeal artery, or the MCA. A stroke in this area would actually damage a large area of the brain and cause a lot of swelling. Now, most of the time, this is not a major problem, but within the confines of the brain, the swelling has no other place to go, and it can cause torsion or shifting of the middle part of the brain, which is the brainstem, circled in this red circle over here. And the brainstem gets shifted or torted, it can be damaged, and this can be life-threatening, and that is because the brainstem controls vital functions such as the person's heart rate and breathing. What surgeons can do then is they can perform this surgery called a deep compressive craniectomy, where they remove skull from around the damaged parts of the brain to allow it to shift outwards, to limit the pressure on the brainstem, and to preserve the stroke patient's life. And the result of this surgery is very significant. Now, the bar charts show the difference in outcomes for patients who undergo decompressive craniectomy and those who do not. Those who do not are in the conservative bar shown above. You can see that the mortality in these patients is 71% versus 22% in those who have undergone decompressive craniectomy. So this is a highly efficacious and life-saving treatment. So what else can we do to prevent a stroke from reoccurring? Well, I will just bring up hypertension because it is a major modifiable risk factor, as well as two other conditions that are amenable to surgery or procedures, and that is the closure of the patent foramen ovale and carotid revascularization. Now, hypertension, as we all know, is a major risk factor for strokes. And for primary prevention, we know that it reduces your relative risk of getting a stroke by about 32%. And what's good about it is that it doesn't really matter what drug you use as long as the blood pressure is controlled. Although some guidelines, like the European ones, now suggest that the initial treatment should be with a calcium channel blocker or angiotensin receptor blocker. But how high or how low a pressure should we aim for? Secondary prevention studies have suggested that the lower we go, the lower the risk of a recurrent stroke. And that goes all the way down to a systolic blood pressure of 120 millimeters mercury. And This has been shown to be true regardless of your age, whether you're young or old. Reduction of blood pressure reduces the risk of you getting a second stroke. So, PFO-related strokes, or the pattern foramen ovale related strokes. Well, what is the pattern foramen ovale? It is a flap in the heart that exists when we were in the womb, in the uterus. And this is supposed to close after we are born. However, in about 20% of the population, this PFO flap remains open. Now, how does that cause a stroke? Well, to help us, we have a short animation. Now, this is a picture of the heart, and we're zooming into the heart right now, showing us the 4 chambers. The top 2 chambers, of course, are the atria, and there's a septum between them, the interatrial septum. And sometimes there is a flap that exists between the two, where a clot, illustrated in yellow, can pass through. Now, this clot can travel from the left atrium, then on to the left ventricle, and following the left ventricle into the aorta, where it goes into the general bloodstream. And that's where the problem occurs, because then it can follow one of the arteries that lead to the brain and occlude a smaller artery in the brain and cause a person to get a stroke. So what can we do for PFO-related strokes? Well, logically, if you close it, you should prevent such strokes from recurring in the future. So this is how the cardiologists at Mount Elizabeth Hospital do it. And again, I'd like to show you an animation. Usually, through a vein in the leg, a catheter is introduced over a guide wire, and we follow this all the way into the right atrium of the heart. Our cardiology colleagues then would carefully guide it across the interatrial septum, across the pattern foramen ovale, over from the right atrium to the left atrium, and from there, they usually deploy an umbrella device. They pull it back to the interatrial septum, over to the other side, whereby they deploy the other half of the umbrella. In this way, they sandwich the pattern foramen ovale together to close it. The catheter is then detached after the procedure, and the 2 discs are then left behind, and the PFO is sealed. Next up, I'd just like to mention to us carotid artery disease, or carotid artery stenosis. This is the disease that causes narrowing of the carotid arteries, the large arteries at either side of the neck over here, that go up to the brain to supply oxygen-rich blood to the head and the face. Carotid artery stenosis is not so common, but it has been shown that if you have a severe stenosis, meaning about 70% or more, and a stroke on the same side of the brain, the risk of you getting a second stroke within the next 2 years is extremely high. It's about 25%. Hence, a revascularization procedure is usually recommended. So, carotid revascularization. Now, this is usually done in 2 ways. Carotid endarterectomy, or open surgery, is where a neurosurgeon or a vascular surgeon cuts open the outer layer of the carotid artery and exposes the lipid core inside. This, he will then carefully dissect out to restore the internal lumen and repair the artery afterwards with sutures. The alternative method is with stenting, where a metal cage is used to prop open the artery. Both methods have their difference in risk and complication types, and no one method is always better than the other. So it's not that one person should always do an endarterectomy or they should do a stenting. Most of the time, we would recommend one or the other procedure based on the individual's risk profile. And as you can see from the bar charts that I'm presenting over here, the greater the degree of stenosis, the greater the degree of narrowing in the carotid artery, the greater the risk of another stroke, and the earlier you do the revascularization, the greater the benefit. In fact, for patients with milder stenosis, those with 50 to 69%, if you were to delay the surgery beyond 12 weeks, it is suggested that the risk of the surgery might be bigger than the benefit you could accrue. So it is important to do this surgery as soon as it's feasible. With this, I've come to the end of my slides, and I'd like to open up for questions if there are any. Thank you.
And that was Dr. Wee Chee Keong, a neurologist at Mount Elizabeth Hospital in Singapore. To our guests, if you have any questions, let me ask you to hold on to them as we will first proceed with our second presentation before doing the open forum. Dr. Wee already gave us a hint as to what to expect from our second presentation. To discuss the heart and brain connection with us is Dr. Edgar Tay, who is already here in the webinar with us. Hello, Dr. Tay. Good afternoon. He is a cardiologist practicing at the Asian Heart and Vascular Center, as well as Mount Elizabeth Hospitals in Singapore. Dr. Tay's subspecialty is in adult congenital interventional cardiology and pulmonary hypertension. He has also authored several book chapters and many peer-reviewed research articles and won the Young Investigator Award in 2015. Let's all welcome Dr. Edgar Tay.
Hello, I'm Dr. Edgar Tay. I'm a cardiologist based in Mount Elizabeth Novena Hospital in Singapore. Today's talk is about the heart and the brain, two very distinct organs but very closely linked to each other. What is the role of the heart to the brain? Well, it appears that the heart and brain are actually two separate and distinct organs. There are actually very close ties between the two. The brain controls some of the crucial aspects of the heart, such as the heart rhythm, as well as the contractions of the heart, while the heart supplies oxygen-rich blood to nourish it every beat. In this slide, you can see very complex interactions between different sections of the brain and its impact on the heart function and the heart rhythm. In fact, it is well appreciated that acute or sudden injuries occurring to the brain can result in significant electrocardiogram changes or even heart failure in patients. You must have seen in some movies people clutching the chest when they're under severe emotional states of anger or fear. In fact, we call this the broken heart syndrome, where a very severe emotional state leads to sudden heart failure or even death in some patients. Can a stroke event be necessarily linked to the heart? Well, strokes can certainly be related to the heart. We know that for many years. The first reason is that there are common risk factors that impact on the arteries supplying the heart, as well as the brain. This results in what we call a process called atherosclerosis, or blockages to blood flow. The second is a less well appreciated but important cause where a blood clot originates somewhere from the heart and then migrates through the blood vessels and that goes to the brain, causing an obstruction to blood flow, and this results in damage to the brain, or we call a stroke. Here what you see are the common well-known risk factors that affect both the heart as well as brain arteries. How do we know then for certainty that there are certain cardiac reasons for strokes? Well, in a recent study that we have done, this actually was involving patients who had strokes. All these patients underwent a routine heart scan, and we found that in 15% of these patients, a significant cause of these strokes were coming from the heart. Today we will discuss the two most common reasons for these patients. Number one is a structural defect within the heart, and the second is due to an abnormal heart rhythm. The structural defect that we should know about is called a PFO. This is a short term for patent foramen ovale. This is an important passageway needed for fetal life. We all have it when we were developing in our mother's womb. However, this passageway usually closes after birth. In a quarter of us, however, this passageway remains open, and therefore this allows clots to migrate through the defect and cause stroke. The subsequent video will show you how this actually occurs. Atrial fibrillation, or AF for short, is a chaotic, irregular rhythm that occurs due to age, heart disease, hypertension, or thyroid disease. When the heart loses its regularity, the pump function of the upper chambers of the heart begin to tremble rather than contract. This leads to an uncoordinated blood flow within the heart that tends to cause blood to stagnate and form clots. These clots can then break off and then follow blood flow through the blood vessels and then occlude the blood vessels in the brain, causing a big stroke. This image that you see now shows a clot in the heart chamber and shows a clot form that is on its way to break off and is just about to cause a stroke. So who is at risk? To remember what we have discussed, we need to understand the types of strokes caused by the heart, and these may be related to age. In younger patients, we tend to see strokes related to the patent foramen ovale type, while in older patients, we tend to see those associated with atherosclerotic disease or atrial fibrillation. What are the tests or medical options available? We essentially try to evaluate the cardiac-related causes of stroke. A screen of the risk factors like diabetes and cholesterol is done by doing a simple blood test. A 24-hour ECG monitoring or Holter is done to look for atrial fibrillation. The last three tests that you see here are tests needed to rule out a patent foramen ovale. Here we illustrate a transcranial Doppler on the left of the screen. Some bubbles are injected into the vein in the patient's arm, and an ultrasound is placed in a location to detect blood flow in the brain. Typically, bubbles from the arm are unable to reach the brain if there is no PFO. If there is a PFO present, these bubbles will then be detected on the scan. If you look at the picture on the right, this shows a different test. Here, bubbles are injected into the vein of the arm again, and we use an ultrasound to see if the bubbles actually directly cross the PFO. There are also new tools which patients can use to look for atrial fibrillation. These include smartwatches with the ability to detect atrial fibrillation, as you can see in the slide here. The first thing to do is to get an accurate diagnosis of how the stroke happened as a result of the heart. Is it due to atherosclerotic disease and risk factors, or is it due to PFO or atrial fibrillation? If it's due to risk factors, we can treat the diabetes and high cholesterol or the hypertension. If it's due to atrial fibrillation, we may give these patients oral medications like blood thinners, and this will be especially useful to reduce the stroke risk. If it is due to PFO, these defects can be closed with a minimally invasive procedure. This is how a PFO is closed. First, a tube or catheter is placed across the PFO, and then we deliver a spring-like device which opens a disc on the right and left side of the heart. These two discs then sandwich the PFO and stops clots from crossing this defect. While blood thinners may be effective in most patients, some patients may face difficulties due to the bleeding complications associated with these medications. In such a situation, we now have an alternative option. We call this an appendage closure procedure. A plug is placed in the section of the heart where clots most likely originate. This will seal the orifice of this device and reduce the stroke risk. Finally, we can summarize that strokes can be related to the heart. A strong relationship between the cardiologist and neurologist is therefore crucial. We have thus formed a heart-brain team for this purpose, and we feel that this provides the best care for our patients. I've come to the end of my presentation. Thank you for joining me.
Thank you, Dr. Edgar Tay, a cardiologist from Mount Elizabeth Hospital in Singapore. And now we will be moving on to our open forum. Let me invite Dr. Wee and Dr. Tay to join me in the spotlight. So kindly open your cameras, please. And to those who have questions for our specialists, we encourage you to type in your questions related to today's topic via the chat. For non-medical or general questions regarding Parkway hospitals, we will answer them via private message or email. You may put your questions in the feedback forum, which we will send at the end of the program. All right, so while we're waiting for the questions to come in, let me just express our gratitude to our specialists on behalf of everyone behind Parkway Lives for being here and sharing your knowledge with us. Dr. Wee, as you've mentioned in your presentation, stroke is one of the leading causes of death worldwide. And just for the information of our guests today, according to the latest WHO data published in 2020, stroke deaths in the Philippines reached around 74,000. So that's 11% of total deaths. And a paper published in the Frontiers in Neurology journal in 2021 states that from 2009 to 2019, stroke remains the second leading cause of death and one of the top 5 leading causes of disability in the Philippines. So I'm sure everyone here knows how significant stroke awareness is. So without further ado, let's open the floor for questions. So I'll begin. Both Dr. Wee and Dr. Tay mentioned PFO and how it normally closes after birth, yet for some, it does not. So Dr. Tay, you also mentioned 3 tests to rule out PFO. Could you let us know a bit more about these tests, and are these non-invasive procedures?
Okay, so to actually diagnose PFO, we mentioned that they've been paying good attention to the approximately 3 different tests. The most accurate is something called a transesophageal echocardiogram. That really is like an endoscopy procedure. We put a probe down the mouth, and that allows an ultrasound to be done from the good tube outwards. And that allows us to see the PFO perfectly clear. And then we can inject some agitated saline, and that allows creation of some what we call bubble contrast. And the bubbles then pass, if there's a PFO, these bubbles will pass. That's the most accurate way of picking up PFO. There are other types of tests, for example, a transthoracic echocardiogram that is done externally with the assistance of injecting some bubbles, but we find that accuracy is only about 70 to 80%. 20% chance we miss some. And then the neurologists also have a test, it's called transcranial Doppler. That is a pretty sensitive test as well, but it has to be done in the right setting because it's not easy to integrate this test. Sometimes you can make wrong judgment as well. So in essence, yes, there are 3 different tests, but as a cardiologist, if you want to be really very sure, the gold standard is transesophageal.
Sorry, Dr. Tay, do you have a mic perhaps? It's a little choppy and we couldn't catch a bit of what you were saying.
I don't have a mic, so I think earlier on the mic wasn't working well. Can you hear me better now?
Oh, we can hear you, but it's kind of cutting out sometimes. Can you try again, sir? Do you have earphones perhaps?
I don't have it with me at the moment.
Okay, I think
I'll try. So maybe I'll just focus a little bit on the transesophageal echo. So that's the gold standard for treating for diagnosing the PFO. It's like an endoscopy procedure where we put a tube down the mouth that allows us to see with much clarity where the PFO is. The other 2 tests, the transthoracic echo, which is done externally, or the bubble-assisted transcranial Doppler, is a little bit less, it's pretty sensitive in the transcranial Doppler, perhaps a little bit less sensitive in the transthoracic echo. So those tests also need to be interpreted very carefully. So if you ask me which is the best, the transesophageal echo is probably the best.
I see. Okay, thank you, Dr. Tay. Dr. Keong, is there anything you would like to add regarding this?
Well, if I might want to chime in, so to understand the transcranial Doppler better, you can hear me, right?
Yes.
I'm just testing this.
Yeah.
Okay, so the transcranial Doppler is where we try to insonate the patient's middle cerebral artery through a probe on the skull, like how I'm holding my pen over here. Then you can actually, in some people, not all, actually visualize the middle cerebral artery. Then what happens is you would inject a bubble contrast solution, basically agitated saline or a dedicated contrast solution into the veins, and see whether it appears in the brain. That would then tell us that the bubbles have crossed over a PFO and gone up into the brain. But as Dr. Edgar has mentioned, this is a pretty sensitive test to pick up that bubbles are crossing from the vein and somehow going up to the brain, but it doesn't confirm that it is a PFO, although we suspect the PFO is most likely the cause. So we would have to actually directly visualize it with echocardiogram or other images of the heart to demonstrate the flap that we believe to be there. Am I making sense to you?
Yes, thank you.
Okay. Yeah, so why it is difficult is because as we age, the thickness of our skull grows, and so for many of the older folks, we are not able to visualize the middle cerebral artery. But since PFO is a condition important mainly in younger stroke patients, we can do that in a number of them. But for others, unfortunately, because of how things are, it just cannot be performed.
I see. Okay. All right. Well, thank you for that additional information, Dr. Keong. If there's nothing else you'd like to add regarding the PFO, we're going to move on to our second question, which is regarding atrial fibrillation. So we also heard a bit about this condition and how these are detected. What are options for those found with this condition?
I think Edgar's trying to talk, but he's muted. Yeah.
Yes.
Can you hear me now?
Yes.
So atrial fibrillation is actually detected best with a electrocardiogram or an ECG. But what happens is that a lot of times these atrial fib episodes or AF episodes are not constant all the time. So it could happen intermittently with normal heart rhythms, then atrial fibrillation, then normal heart rhythms again. And we call this intermittent or paroxysmal atrial fibrillation. So in order to pick these things up, there are two options. One is to hook up what we call a Holter monitor, which allows us to see the ECG continuously, perhaps for 24 hours, all the way to 5 days. But that requires the patient to wear a what we call a Holter monitor, a kind of an ECG that's hooked onto the patient. Mm-hmm. And then there's a little, almost like a cassette tape kind of device that the patient has to be holding on to. What's more popular nowadays is that there's a lot of these consumer watches. Some of you may have heard of the atrial fibrillation protocols in the iPhone.
Okay.
And that really is changing the field quite a bit. So we have a lot of patients now picking up atrial fibrillation actually through these watches. Mm-hmm. So I think this will make a big change in the improved detection rates of atrial fib.
So when a person has, let's say, palpitations, does that automatically mean they have atrial fibrillation?
No. So palpitations is kind of non-specific. It could be related to kind of other forms of irregular heartbeat, and it may not always be atrial fibrillation.
Okay.
To diagnose atrial fibrillation, I say you can feel the pulse. If it's a totally chaotic rhythm with no pattern to the cadence of the pulse, and no rhythm at all, then that is typical of atrial fibrillation. So we can't make a diagnosis just based on palpitation.
And even after, for example, you were diagnosed with atrial fibrillation, what is the next step?
So after diagnosing with atrial fibrillation, there are two key considerations. The first is to find out whether there are any other causes that have triggered the atrial fibrillation, or whether there's anything structurally abnormal with the heart. So that would include things like ruling out abnormal thyroid hormones, for example. Look for things like diabetes, hypertension. These are the typical causes. Then look at the heart, whether there's structural abnormalities, like whether there is thick heart muscle, or if there is valve abnormalities with the heart. These are the common causes for atrial fibrillation. So the first bit is to try to understand why this has happened. The next thing is to look at relieving the patient's symptoms. So if the patients have palpitations and they don't feel well with it, then we use certain medication to relieve those symptoms. The third most important thing is atrial fibrillation is very, very strong risk factor for developing stroke. And that's why we're having this very important discussion today. And this is the key focus. So we need to make sure we pick up atrial fibrillation, most importantly, because we need to prevent stroke. And to do this, you've heard the talks, we need to either give them an anticoagulation if they can, in the case of most patients. And in the case if they can't, then we have the alternative left atrial appendage to the procedure for some of these patients who can't tolerate a blood thinner.
Okay, all right. Thank you, Dr. Tay. So this next question is for Dr. Keong. So Dr. Wee, you also mentioned procedures such as PFO closure and carotid revascularization. So these procedures are also available in the Philippines, although they're not routinely done. What do you think are the key factors patients should consider or ask their doctors before undergoing such procedures?
Okay, so that is actually a very good question. Now, why should a person get this procedure done in any special or any particular place? Let's just go back a little bit, right? So carotid stenosis is not a well, I wouldn't say it's a very uncommon illness, but you see, in order for any person to benefit from a PFO closure or even a carotid revascularization procedure, we must be sure that this is the cause of the stroke. If you remember in my talk, I think I might have mentioned that up to 20% of the population have a PFO, right?
Yes.
So you cannot just close 20% of the PFOs in the population. It simply doesn't help them. You got to find a PFO in a stroke patient and one that looks like it's causing the stroke. Okay. So firstly, identification of a suitable lesion, a suitable PFO, not just any PFO. The same is true for carotid stenosis or carotid artery narrowing. You got to find one that is relevant to the person's stroke. And that is first true with a thorough evaluation of what the underlying cause of the stroke might be before you determine its efficacy and benefit in the person. And once you determine that, then once a decision has been made, then you will want to make the decision to intervene either with a PFO closure or carotid revascularization. So that usually, in my thinking, should be done in the center where there's close collaboration between the various teams of doctors who are doing this. You don't just look for a very good proceduralist or a very good surgeon who's very good at closing PFOs, or a person who's very good at doing carotid endarterectomies and ask for that procedure to be done. You have first got to be in the center to determine that this is important, a beneficial lesion to treat, and then with that same team of doctors decide to treat the problem in the most effective way possible. Then once you've decided to close the PFO, a question that I would want to ask the procedurist, pardon me if I put you in a hard spot, Edgar, is to ask, firstly, what are the published risks of doing the procedure? And that is, I think, that's what holds true for any procedures that the person goes for. What are the general international published risks for doing this procedure? What are your own published risks of doing this procedure? And what do you think the risk in my particular circumstances? Because it doesn't matter what the general risk is. It doesn't matter how good the surgeon's skills are. What matters to me is how dangerous it is for me. And that is modified by what kind of condition I have. If I have multiple medical problems that are uncontrolled, my risk is higher. So that's going to affect my decision whether I even want to do the procedure or not. Yeah. So that holds true for all procedures. Then if you were to talk about carotid revascularization, then you want to do that in a center that offers both stenting and endarterectomy, because there's two ways to do it. Yes. And it is not always true that one procedure is better than the other. They are both different. They carry differential risks. And for selected people, it might be better to do a stent. For selected people, it might be better to do the endarterectomy. So you want to be in the center where you can be offered the most beneficial or most or the least risky procedure. So these are the things I would consider before I choose whether to undergo a procedure or not, and which center I want to do it at. And I think it's a universal recommendation I would give for most conditions.
I see. And Dr. Tay, would you like to add anything regarding that matter?
Yeah, I think what Chee Keong said was absolutely spot on. I think the role of the heart-brain team here is really important. It's not just one person just going in blindly to kind of do some procedure for the patient without thinking of the patient as a whole. And in fact, I think most of these patients who have a stroke, and then when they think about whether they need a PFO closure or not, the first thing I do is give Chee Keong a call and actually get his opinion about whether we believe that the PFO is the culprit even for the stroke. Because not every, PFO occurs in about a quarter of the entire population, and not every patient would benefit from this closure. So the first thing is the neurology team member is very important to get the diagnosis right, the type of stroke, and also to assess what is the probability of the stroke being the culprit here. And then, of course, while that's important, of course, the proceduralist personal experience and the volume of cases done is also extremely important. Because as you know, most procedures, the more patients you have treated, the higher the chance of success and probably the lower the rates of complications. It's also important, like what Chee Keong said, to put the patient in the main center of the picture, because you can have all these guidelines and all these papers predicting all the kinds of risk and the things that can happen, whether it's benefits or risk. And really, it's down to us as a team to decide what is best for this patient and what is the exact benefit and the exact risk. So I think that's why it's not a one person decision, but really a heart-brain team here.
Right. Okay.
Absolutely. Absolutely. I mean, I always ask Edgar whether you think this is the culprit. And sometimes when we cannot make the decision, we observe the patient for a while, we take our time to run through it, and then we revisit the issue again and again with the patient before we finally make the decision. I think a suitable amount of care has to be taken before we offer any intervention. Yeah, Edgar?
Yes, absolutely.
All right. Okay, well, I have one final question for you doctors. This is from our team. Medical and surgery were both mentioned as means to treat stroke. Apart from that, what kind of lifestyle changes can be done to treat stroke? And for example, what exercises are allowed or what food should be avoided?
So for stroke prevention, the biggest thing that you can do to reduce your stroke risk, lifestyle-wise, is to quit smoking. If you are a smoker, just don't do it. It's not good for anything at all, that I understand. Okay, but if you talk about exercises and stuff, then it's the usual cardiovascular risk prevention exercises that we recommend, about 20 to 40 minutes, 3 times a week, get the heart rate up to about 60 to 80%. This is what you need to do. And that's good for everything, not just the brain. It's good for the heart too. Yeah. Diet-wise, most of us would recommend a Mediterranean diet. With balanced amounts of vegetables, low amounts of saturated fat. This is something that I think holds true for both the heart and the brain's vascular health. But where the brain varies slightly differently from the heart is somehow the intake of vegetables doesn't seem to benefit the brain so much, but the intake of fruits does help. So taking fruits, vegetables, lean meat, and a diet with higher in omega-3 fatty acids seems to be the most protective for stroke prevention. Since it's also related to heart, because it's the same vascular system, Edgar, I wonder if you have anything more to add?
No, I think you've mentioned most of the important the risk factors that we need to be aware of. Of course, if you are of the certain age and you think you have a strong family history, you may want to speak to your family doctor. To look at the basic risk factors, like look for simple things like hypertension, cholesterol, diabetes. And of course, just remember that atrial fib is always very quiet in the background. And if you have palpitations, be it during exercise or at rest, don't totally dismiss it. Think of possibilities of atrial fib, discuss with your family doctor, and then be aware that these things are related to stroke.
Yeah, my own mother has got atrial fibrillation and she needed a pacemaker at the end. All she presented with was she fainted a few times. So especially when you grow older, please do screen for that. Yeah.
Right. So Dr. Tay, you mentioned again palpitation, and we have an audience member asking, Miss Eula wants to know, is palpitation an indication that you have a heart disease?
It may or may not be related to heart disease because palpitations are firstly very, very common. In fact, you look at all the diagnosis, the symptoms that patients come to see the general cardiology clinic in most hospitals in most countries. One of the top symptom is palpitation, but the majority of these after screening will actually turn out to be okay. And they could be a variety of things. People who are stay anxious or they're taking certain medications to make their heart rate faster. Those can cause patients to feel like they have a fast or stronger heartbeat. But we shouldn't dismiss them. If the patients have palpitations that is persistent and it's happening at rest, it means you're not really doing very much and you have a palpitation which is a bit less common. And also if it's related to certain symptoms of importance, so breathlessness, chest discomfort or dizziness. if it's associated with these three symptoms, then it's more likely to raise a concern, and you probably should have it checked with the doctor.
Okay, all right. We also have a question from Arlene. I am a diabetic patient and having hypertension. Will it be beneficial if I'll take aspirin before sleeping?
Oh, maybe I can take that one. I think that's a very good question. If a person has got very high risk, having very high risks of developing a heart attack or a brain attack like a stroke, why do we wait before taking aspirin? You know, if I know I'm going to get a stroke, the best time to take aspirin is before I have the stroke, and don't even get a stroke. Yeah, makes sense. Unfortunately, based on our risk stratification so far, our ability to predict a stroke is not that high. So most of the studies, most of the trials will be done for primary prevention by starting blood thinners. That means we divide people into two arms. One with, ouch, sorry, I sprained my arm. One group of people with high risk factors who don't take aspirin, and one with high risk factors who take aspirin. We have seen no benefit in stroke prevention. What we have seen though is increased bleeding in patients who take aspirin. So for primary prevention now, we do not generally recommend it for most patients. You might want to decide to do that after you have discussed your specific risk factors with your family physician, cardiologist, or neurologist. But this is not something we generally recommend to all patients.
Okay. So there was actually, I read something, if it's a myth or a fact, that aspirin is a home remedy for stroke. Any reactions to that?
You mean you treat yourself with aspirin at home and not come to the hospital?
Yeah.
Is that the question?
Is that a myth or a fact that aspirin does help with stroke?
Aspirin is what we give for acute ischemic strokes. But if you have a stroke at home, you have symptoms of a stroke, 20% at least would be hemorrhagic strokes, meaning you have a bleed in the brain. If you were to take a blood thinner when you have a bleed in the brain, that is not going to be a good idea. So don't treat strokes at home. Get to the hospital, see a doctor, get some imaging done. Okay.
All right. Thank you, Dr. Keong. All right. We also have a question from Clarence. Do you think that having a past COVID infection will play a role in stroke, especially when someone claims that long COVID has to do with blood clots?
That is a very good question. Now, I think in the last 2 years, we learned a lot about COVID. So the question is very, the answer is going to be a bit complicated. Now, during acute COVID infection, are you at increased risk of getting a stroke? Yes, you are. And we have demonstrated that young people with acute COVID have suffered from large vessel occlusion strokes. That means the big blood vessels in the brain get blocked when they have COVID. And in the next 30 days or so, the risk of stroke seems to be higher. And this is associated with the COVID infection as well. But how long after this does this continue? Does it go on for more than a month? We don't really know for sure. Definitely, if your risk, if you had a COVID infection about 1 year back, I don't think your risk is much higher now than you would have been if you hadn't had the COVID. And of course, this is personal opinion. The data is still out there. But I don't believe that COVID can cause such a prolonged pro-thrombotic, meaning a pro-clotting state in the body that your stroke risk is elevated for prolonged periods of time. But during the COVID and during the next 1 month or so, the risk is higher. And there have been protocols that have been developed around the world to try to identify people at high risk of developing clots in the circulation, not just strokes, but elsewhere. And these protocols would recommend starting for the short term some blood thinners. And this is in use worldwide in many different countries. So follow the protocol.
And Dr. Tay, would you like to add anything regarding that?
Yeah, so COVID is really kind of a very, I wouldn't say it's a new enemy, but it's like a constant enemy. And other than what Chee Keong mentioned about the risk of clotting and all that, I think specifically from the cardiac point of view, we have seen increased rates of people developing new onset atrial fibrillation. which is quite common as well during acute COVID or shortly, even a couple of weeks following COVID as well. And the patients present with palpitations, and when they come or bring the Apple Watch, they show us the trace. And so we have seen that we're not sure how there's some scientific basis for how COVID can relate to atrial fib, but certainly any viral infections have been shown, even influenza seems to trigger some patients' atrial fibrillation episodes. And of course, if this happens, atrial fib itself then becomes a risk for stroke. So it's not COVID directly causing the stroke, but COVID causing atrial fib then leading to strokes.
It's like a chain reaction.
Correct, yeah.
Okay.
So we have to take care of these patients properly.
So unfortunately, we don't have time to answer all the questions of our guests today. So if you guys have any questions, kindly email there. It's in the chat box, or you can send your messages via Facebook. But before we end the open forum, earlier we had a quick icebreaker game. It's called Myth or Fact, and we have 5 statements. So Dr. Keong and Dr. Tay, can you just answer quickly if you think this is a myth or a fact? So our first statement is, a second stroke will have worse effects than the first. What do you think? Myth or fact? It was a bit divided in our icebreaker activity. Some people thought this was a fact. Some people thought this was a myth.
I would say 50-50. So it depends on what the question is. And as with all good questions, it is worded in the ambiguous enough manner that they can answer both yes and no. Okay, anybody who has a stroke before, after suffering a second stroke, would be worse off than if they only had the first stroke. So of course, the second stroke is worse than the first stroke. Definitely. Okay, if you had one stroke, you had a second stroke, your function will be even worse. But the second stroke doesn't have to be a major one. Maybe you just have a tiny, in fact, a small little stroke in the brain, whereas the first stroke can be a very big one, which affects a large area of the brain. So depending on what you are actually trying to ask with that second stroke question, the answer can be yes and no. As in, you can have a big first stroke and a small second stroke.
Okay, but if you get the second stroke,
but if you get another stroke, you will definitely be worse off. So what is the question?
Is this a myth or a fact?
So what is the question referring to? Is the second stroke going to be a bigger stroke, or will you be worse off after the second stroke?
Will the second stroke have a worse effect than the first? Well, I think you kind of answered this somehow. Dr. Tay, what do you think?
I will kind of leave this answer to Chee Keong. He's the expert here. But to me, I think I agree. I think the second stroke, especially in the atrial fib, I think there's some data that also suggests that if a second stroke occurs, it tends to be worse off than the first in some cases. So I would say fact.
Okay. And our second statement is, only old people experience strokes.
Oh, myth.
That's it. Yeah, myth.
I think all our audiences got this as well. Only old people experience strokes. And the third one is, women are not likely to have strokes. I want this to be a fact as a woman, but myth or fact?
Stroke is not sexist.
I did read somewhere that women are less likely to have strokes, but I don't know where that came from or why there's a statement like this going around the internet. But it's a myth, right?
Well, if you look at the epidemiology, depending on the country, in some cases, men are slightly more likely to get strokes. In some other cases, women are slightly more likely to get strokes. The reason is not very clear. Maybe because men tend to lead more dangerous lives, like smoking. So we don't really know for sure. But even if there's a slight gender difference, it's usually in the difference of about 5% or so, not very much. So women are pretty likely to get strokes as well.
All right. Since you mentioned smoking, actually, that's our fourth statement. Smoking raises your odds of getting a stroke. Myth or fact?
Fact.
Fact.
Okay, I think most of our audience has got this as well. And the final one, the final statement, people were kind of divided by this was as well. All strokes have noticeable symptoms. Dr. Keong, you're shaking your head vigorously. Myth?
It's a myth. Yeah, it's a myth.
Care to elaborate?
Okay, so depending on the area of the brain cells damaged in the stroke and depending on the function of the cells, some strokes have relatively minor symptoms. And also noticeable depends on a few things. Now, if I told you what the symptoms of a stroke are, then you would notice it more. You have been pre-primed to look out for the symptoms. Then you know that it is a stroke. But for some other people, if they have a bit of a, let's say, a bit of a numbness on one side or the other, and it doesn't affect their function much, and they're a very busy young person who think that they're immune from getting stroke, they wouldn't notice it, and it just passes. So not all strokes will produce a significant impairment, and those with minor impairments will not be noticed by people who think that they cannot get a stroke. On top of that, we do get people with silent strokes, which is strokes that occur in the area of the brain that are relatively silent. They don't produce very obvious effects like strokes in the frontal lobe, for example. We do often pick up one or two of those when you do a scan for other reasons, and we see that the person has got a scar in the brain, and that's consistent with the old stroke. So not all strokes would produce a noticeable symptom. That's because for some of them, they produce essentially almost no symptoms. In other cases, the symptoms are relatively minor, and if the person isn't primed to look out for it or believes that they will not get a stroke, they simply do not notice it. So complicated answer, sorry.
That's fine. So you mentioned earlier that you were able to scan and saw old scars. You mean these people had a stroke, didn't know they had a stroke, and they came in for a checkup completely unrelated, and they find out they had a stroke that they didn't know about?
That is right. And you see a scar in the brain, and within the area of gliosis in MRI scan, there's an area of brain cell loss. So we know that was a stroke.
Oh, okay. That's quite scary.
Mm.
What about the silent strokes where?
So those are the silent strokes, yeah.
Do people just drop dead sometimes?
Those would be silent strokes. I mean, silent by definition means they have no symptoms, right?
That's scary.
Yeah.
What do you do?
If you talk about sudden death, that's usually in Edgar's field where you have sudden cardiovascular collapse. But silent strokes would produce no symptoms.
I see. Okay. And Dr. Tay, is there anything you would like to add?
Yeah, I think the discussion is pretty nice. I mean, it's not just kind of being aware of these cases where there are gross weakness being stroke. We need also the audience to know that there are some patients who have less severe symptoms, sometimes just a clumsy movement of the hand, or even sometimes just vertigo, like a dizzy spin, dizzy spell, for example. Some of these things, like what Chee Keong has mentioned, are pretty important, but may not be typically known to some people, that this could be actually a warning sign. So if symptoms persist or recur, it's really important to have these checked out and not wait too long, because you can have multiple episodes of what we call transient ischemic attacks or small kind of warning symptoms, but if you miss it, then a big stroke comes along and then it's too late.
Right. Okay. All right. So that is the end of our open forum. Thank you so much, doctors. And we are nearing the end of our webinar, Parkway Live. So we've talked about stroke prevention and management, as well as the heart and brain connection. So thank you, Dr. Wee and Dr. Tay, for raising awareness on these topics and leading our discussion. Although our esteemed guests are all the way from Mount Elizabeth Hospital in Singapore, why don't we have a look at the Parkway Hospital Singapore Philippine office?
Never. Our health means everything. And when the need arises, the best healthcare facilities are closer than you think. A smooth medical journey from the Philippines to Singapore is now within reach. At the Patient Assistance Center, operated by Parkway Hospitals, Singapore, patients are provided with fuss-free access to quality healthcare. Located at the ground floor of Marco Polo Hotel in Ortigas Center, Pasig City, the Patient Assistance Center serves Filipino patients and their families who need support in medical and travel arrangements. The center connects Filipino patients to the world-class medical care and offshore medical treatment of Mount Elizabeth Hospital. Mount Elizabeth Hospital has been serving the Asia-Pacific for over 40 years as a medical hub in the Asia-Pacific region. Its strategic pairing of medical talent with revolutionary medical technology paved the way for its Joint Commission International accreditation, the Gold Seal of Approval for Quality Healthcare. The one-stop shop concierge offers services such as medical referrals and appointment booking, evacuation and repatriation assistance, flight reservation, visa application and extension, accommodation arrangement, airport meet and greet service and domestic transfer arrangement, direct admission arrangement assistance before, during, and after hospitalization, multi-language translation and interpreter service, hospital billing and financial inquiries.
Singapore is a country that has a reputation for excellence, and this includes excellence in healthcare. Hospitals and medical centers there are globally esteemed for their exemplary service and modern facilities. Among them, Parkway Hospital Singapore is a group of 4 premium hospitals, and they provide world-class, top-notch medical experience. Philippine patients can now access the services, experience, and the medical expertise of Parkway Hospital Singapore through the Parkway Patient Assistance Center, or what we call PPAC, which is located and operated in the Philippines.
For the longest time, I wanted to get an appointment to Mount Elizabeth Hospital in Singapore, but I was uncertain who would be the best specialist for my needs. I am glad I discovered the concierge services of Parkway Hospital's Patient Assistance Center to provide the necessary support I need in my travel and medical arrangements. So I went to their office in Ortigas to inquire about diagnosis and treatment options. They then scheduled a telehealth consult, an online and instant connection from here to medical experts based in Singapore. I was referred to a specialist, and they even gave me the details of the number of similar cases handled by that doctor. If you don't want to stress over the process of acquiring a healthcare service in another country, give the Patient Assistance Center a call and let them do the rest for you. The caliber of their service is truly best in class.
Choosing the best healthcare really matters. Our team at Parkway Philippines is committed to serve. We look forward to the beginning of a fruitful health-centered partnership.
Whatever your health concern may be, access the wide spectrum of medical services of Mount Elizabeth Hospital Singapore through the Patient Assistance Center. We are here for you.
Once again, thank you to our esteemed doctors for being here today and helping raise awareness on stroke. We would also like to thank all of you, our guests this afternoon, for attending today's webinar. Parkway Lives, once again, is a series of webinars that will tackle different health topics. If you learn from today's event, stay tuned because we have more upcoming webinars on different topics such as leukemia and cancer, about the liver, kidney, prostate, and a lot more. On behalf of Parkway Lives and its organizers, we thank you for staying till the very end. And on your screen, you will find a QR code, which you may scan, and it will direct you to our feedback page. You can also find the link via chat. We highly encourage you to answer our surveys that we may provide you with better webinars in the future. And we would also like to invite you to our Parkway Hospital Singapore Philippine office in Ortigas. Our staff there will help you with all your needs. All right, once again, thank you for joining us today. My name is Demi, your host in today's webinar. Have a blessed afternoon, and we'll see you on the next Parkway Lives. Thank you, everyone, and have a good day.